Hey everybody, Dr. O here. In this review, I want to cover the heart and the cardiovascular system, or at least most of it. We've already covered blood. We'll cover blood vessels and circulation in a separate review, but we're primarily going to focus on the heart here today. All right, let's dive right in. My voice isn't still 100%, but this is definitely better than nothing. I want to make sure I get the content to you guys as soon as you need it. All right, so what is the difference between the systemic circuit and the pulmonary circuit? So your heart basically has two halves that power two different circuits. The systemic circuit is what sends blood to and from almost all of your body tissues. So the pulmonary circuit is what the right side of your heart powers, and it's going to pump blood to and from your lungs. It's going to take that blood to your lungs so it can drop off carbon dioxide and pick up oxygen. It's going to bring it back to the left side of your heart, which will pump it through your aorta and all your other blood vessels out to the rest of your body. So pulmonary circuit, think right side of the heart to and from the lungs. Systemic circuit, left side of the heart, and it's everywhere else. Okay, what is the difference between an artery and a vein? And it is not oxygenated versus deoxygenated blood. So like when I was younger, I would have learned that arteries carry oxygen-rich blood and veins carry deoxygenated blood or oxygen-poor blood. That's true in almost every instance, but it's not true because of that pulmonary circuit we just mentioned. The pulmonary arteries are actually carrying blood to the lungs so it can drop off CO2 and pick up oxygen. So the only correct definition of an artery and a vein is arteries carry blood away from the heart, veins carry blood toward the heart. Now, does almost every artery carry oxygen-rich blood? Of course, but there is that one glaring exception. So arteries carry blood away from the heart, veins carry it back. All right, what is the key thing that occurs at capillaries that doesn't occur at arteries and or veins? So we'll talk more about blood vessels later, but arteries, like I just said, carry blood away from the heart to whatever destination it's heading to, whether it's your pinky toe or your brain. Veins carry blood back, but that's their primary job, is to carry blood to and from destinations. The capillaries are actually where we exchange things. So think of capillaries as really the only location where you're going to see a lot of exchange. That means that you're going to be dropping off oxygen and picking up carbon dioxide, or dropping off nutrients and picking up waste products. So the exchange of nutrients, the exchange of blood gases is going to occur at capillaries and not at arteries or veins. So arteries and veins are the actual transport system. The capillary is really where all the work occurs, though. And the overwhelming majority, you have between 60 and 100,000 miles of blood vessels in your body, give or take. It takes like 10 miles of new blood vessels to make a new pound of muscle, maybe 7 miles to make a new pound of fat. So obviously you have tons and tons of blood supply. Almost all of that is capillaries, where we're carrying things or transporting things across the capillaries to your cells and back. All right, so that's the key thing that occurs at capillaries. Next, you must know the path that blood takes through the heart. Know the order that blood flows through the four chambers, the valves that it passes through, and when it goes to the lungs. So I always like to start with at the beginning, which, it's obviously it's a circulatory system, so I don't really know where the beginning is. But I like to start at the superior vena cava and the inferior vena cava. So these are going to be your two large receiving vessels, the two largest veins in your body. The superior vena cava is going to drain all the blood from above your heart into the heart. The inferior vena cava is going to drain all the blood from below your heart into the heart. So the inferior and superior vena cava are going to drain into the right atrium. Then when the right atrium is going to fill, it's going to swell as it fills, and when the right atrium contracts, it's going to pump blood to the right ventricles through the right AV valve, also known as your tricuspid valve. So now this blood is sitting in the right ventricle. When the right ventricle contracts, it's going to pump that blood through the pulmonary valve, or the pulmonary semilunar valve, which is going to carry it to the pulmonary trunk, which becomes your pulmonary arteries, and that's what's going to carry the blood to your lungs. So the right ventricle has to contract strong enough to pump blood to your lungs. At the lungs, especially at the gas exchange surface of your lungs, the alveoli primarily, carbon dioxide is going to be dropped off, oxygen is going to be picked up, and now this blood is ready to come back. So it's going to come back through your pulmonary veins, and that blood is going to drain into the left atrium. So now we've left the pulmonary circuit, the right side of the heart. Now we're in the systemic circuit. So when the left atrium contracts, blood's going to pump through the left AV valve, also known as the bicuspid valve, or the mitral valve. Mitre is a term for a bishop's hat, like the big hat a bishop in the Catholic Church might wear. So that's the shape of the valve is where that name comes from. So it's called the left AV valve or the bicuspid valve, meaning it has 2 flaps instead of 3, or the mitral valve. Now the blood is in the left ventricle, which I think we can all should agree is the most important chamber of the heart, because when the left ventricle contracts, it has to be powerful enough to push blood through the aortic valve, or the aortic semilunar valve, to the aorta and then to all of your tissues. Which is why, as you'll see later, the left ventricle is, 3 times as thick, much more muscular than the right ventricle. That blood's going to go to the top of your head, soles of your feet. It's going to then drain back towards your heart through your veins, where it reaches either the superior or inferior vena cava, and we're back where we started. So that's the path that blood takes through your heart and then really through your body. All right, next, what is the mediastinum? So there are lots of ways to describe where the heart is. You could say that the heart's in the thoracic cavity. That just means it's above the diaphragm. You could say it's in the pericardial cavity, which is about as specific as you can get. But another term you might see is the mediastinum. The mediastinum is the space between your 2 lungs. So whereas the pericardial cavity really just has the heart in it, the mediastinum would have the heart, your thymus gland, your great vessels like your aorta, inferior and superior vena cava, other structures would be in there. So the mediastinum is just that space between your 2 lungs. All right, no visceral and parietal pericardium from earlier discussion. What is another name for the visceral pericardium? So hopefully you remember your ventral body cavities. They're these double-lined cavities that have a visceral and a parietal layer. Visceral means organ, so that's going to be the layer that's on the organ itself. Parietal basically means body wall, so that's going to be the layer that lines the cavity the organ is in. The reason these layers are important is because between the visceral and parietal layers, you're going to have a very serous watery fluid, which reduces friction. So when your heart beats, there's not friction between the heart and the structures around it. So that's the visceral pericardium on the heart itself, and the parietal pericardium lining that cavity. So the analogy you always see in anatomy textbooks would be like pushing your fist into a balloon and having that double layer around it, but it's kind of a weak example. What's another name for the visceral pericardium? So if you see the term in this chapter, epicardium, it actually means the same thing. So way back in the first chapter, we would have never used the term epicardium. We just called it visceral pericardium. But epicardium is another name for the visceral pericardium. Just to quickly review, the visceral and parietal pleura would be the double layer of around the lungs, and the visceral and parietal peritoneum is going to line most of your abdominal pelvic organs. Okay, I'm going to sip here. What are the 3 ways that we have classified cardiac muscle tissue? For example, do cardiac muscle cells have a single nucleus or multiple nuclei? So when we cover muscle as a tissue, hopefully remember the 3 ways we look at it. Number 1 is a muscle cell striated or not? That just means, does it have a banded appearance, a real structured, organized appearance or not? Cardiac muscle is. So cardiac muscle is striated, just like skeletal muscle is. Then the next one is cardiac muscle voluntary or involuntary? Well, skeletal muscle is voluntary most of the time. You control it. Cardiac muscle is involuntary. You don't have to tell your heart to contract and relax. So it is striated. It is involuntary. The third thing is, does it have a single nucleus or multiple nuclei? So heart muscle cells, cardiac muscle cells only have 1 nucleus, whereas your skeletal muscle cells have multiple nuclei. So the 3 ways you'd classify cardiac muscle tissue would be involuntary, you don't control it; striated, just meaning it has a banded and organized appearance, unlike smooth muscle; and the third then would be just a single nucleus per cell. All right, so that's the 3 ways you classify cardiac muscle tissue. Next, the other really important feature of heart muscle cells is the next point. So what is an intercalated disc and why do they matter? Intercalated discs are special connection points between heart muscle cells. And the reason that's important is because this allows, like for me to wiggle my fingers here, it actually takes multiple motor units, multiple motor nerves controlling individual or small groups of muscle fibers. So it's actually quite complicated for me just to squeeze my fists. But the heart, it's a special electrical connection so that one stimulus is able to cause the entire heart muscle to contract. And we'll talk about that when we get to the conducting system. So there are special connection points between heart muscle cells that allow them to function as one unit. So that's the intercalated disc. All right, what is the function of the valves of the heart? So valves, whether it's heart or anywhere else, valves prevent the backflow of blood. So the job of the left AV valve, which we also called our bicuspid or mitral valve, is to make sure the blood only goes from the left ventricle, or from the left atrium into the left ventricle. If this valve works properly, when your heart contracts, blood will not go from the left ventricle back into the left atrium. If that does happen, your valves aren't working, you're going to have a regurgitation of blood moving backwards, and that's going to be a murmur. You're going to hear that. So valves prevent the backflow of blood. That'll be the same answer when you're talking about what the valves do in your veins. It'll be the same answer when you're talking about the valves in your lymphatic vessels too. They prevent things from moving backwards. Okay, there are multiple names for some of the valves. You must know them all. Just because I don't know what terms you're going to hear clinically or in your other classes, so I like you to know them all. So the first one we talked about was the right AV valve, which stands for right atrioventricular valve. So it's between the atria and the ventricles. That's also called the tricuspid valve because it has 3 flaps. So that's going to be your right AV valve or your tricuspid valve. That's between the right atrium and the right ventricle. From there, if we're following the path of blood, we go through the pulmonary valve, often called your pulmonary semilunar valve. So they're called semilunar valves because these half-moon-shaped flaps are actually what create the valve. They lean into each other, so it's a different type of valve structure. But that's why they're called semilunar valves. It's called the pulmonary valve because it's the one that keeps blood from flowing backwards as we're trying to get it to your lungs. The next valve we talked about was the left AV valve, left atrioventricular valve, also known as the bicuspid valve or the mitral valve. So bicuspid tells us it has 2 flaps. Mitral, I already mentioned, was because it looks like a bishop's hat, I guess. Somebody thought it did when they named it. So that's going to keep blood from flowing backwards into the left atria from the ventricles. Then the last one we covered was the aortic semilunar valve or the aortic valve. That's the valve that keeps blood from pooling back from the aorta into your left ventricle. So that's all the potential names of the 4 major valves. All right, which chambers of the heart are more muscular, the atria or the ventricles? That'd be the ventricles. So just think about any muscle, right? A muscle that needs to be stronger, needs to be bigger. The atria only need to squeeze a little bit. They basically top off the tanks. When the 2 atria contract during the lub of your cardiac cycle, during atrial systole, they just top off the tank. The fluid movement of blood and gravity have already filled most of your ventricles, so they don't have to be very powerful. The ventricles have to pump blood to a destination. Your right ventricle has to pump blood to your lungs and back, really. Your left ventricle has to pump blood out to your entire body. So obviously your right ventricle has an easier job than your left ventricle, which is why the right ventricle is going to be smaller. Okay, where are we? Define key terms of parts of the heart, the chordae tendineae, or tendinae, some would say, papillary muscles, and moderator bands. So I just kind of chose a few terms that are important that haven't been brought up yet. The chordae tendineae, they're the actual fibrous or tendinous cords that attach the cusps of your bicuspid and tricuspid valves to the papillary muscles. So these valves actually work because these papillary muscles, and papilla means nipple-like, so these little nipple-like muscles inside your heart, which hopefully you'll see when you dissect it or watch videos of it being dissected, these little nipple-like muscles contract, and that tugs on these cords. I can't help but thinking of like the Thanksgiving Day parade where you have people pulling on the ropes to keep those big Snoopy balloons or whatever from disappearing. So it tugs on these cords, the chordae tendineae. And when that occurs, it stiffens up these flaps so the valves will work. So these valves will swing open real easily, but they won't swing the other direction because these cords are being pulled. So the chordae tendineae are the cords. The papillary muscles are these little muscles inside your heart that contract prior to the big contraction of your heart to tug on those cords. The moderator band is a term we'll see when we get to the actual conducting system really soon here in this review. The moderator band is a small piece of the electrical system of the heart, and its job is actually to power these papillary muscles. So these are all related. band. The moderator band tells the papillary muscles it's time for you to tense up. When the papillary muscles tense up, it tugs on those cords. When those cords get tugged on, it stiffens up the atrioventricular valves, or your bicuspid and tricuspid valve. And as long as that's working properly, you won't have a heart murmur, you won't have the regurgitation of blood in your heart, because your blood will all flow one direction, which it's supposed to do. All right, so those are 3 extra terms. Why is the left ventricle more muscular than the right ventricle? So again, I usually would say it's 300% or 3 times as thick. Just think about the right side of my heart has to pump blood to the lungs and back, left side of my heart to the bottom of my feet, and then it has to work its way back. So it has to be it's a stronger muscle because it has to work harder. It has to pump blood harder. It has to push blood against more resistance. Hopefully that makes sense. That's why if you could choose where you're going to have a heart attack, you'd probably choose not to have one, but you definitely don't want your left ventricle to be damaged. Oftentimes that leads to very negative outcomes down the road. If a valve fails, leading to the regurgitation of blood, which I've mentioned twice now, your doctor would hear it while blank with your heart and call it a blank. All right, so hear it while auscultating your heart. So auscultation is the technique where you use a stethoscope and listen to the heart, or you can listen to the carotid arteries or lots of other places too. But while your doctor, while he or she is auscultating your heart, they would hear this regurgitation of blood, and it's a murmur. So compare that to another thing. Like usually when people are talking about heart problems, you might hear them talk about a murmur, which is the regurgitation of blood because the valves aren't working usually, or an arrhythmia. So arrhythmias are going to be problems with electrical activity, which we'll get to in just a moment. All right. So let's see. You must know the path of the conducting system of the heart. So I'll do it all here, but then you'll see it's going to tie into a couple of the other points. The conducting system starts with the SA node. SO stands for sino or sinoatrial node. This is the pacemaker of your heart. So you've all heard of people getting pacemakers. Well, we all have one. You get an external pacemaker, or you get one added when yours quits working. So the pacemaker is this SA node, and it's what's going to start every heart muscle contraction. So the SA node is built into the wall, the back wall of the right atrium, and then when it sends out an electrical signal, it basically will depolarize both of your atria. So that's the first step in the path of this conducting system, the SA node. It's then going to go to the AV node, which stands for atrioventricular node, which is going to be right between the atria and the ventricles, so thankfully the name makes sense. Then it's going to go, now there will be a delay, which we'll talk about in just a moment. So SA node to AV node, then it's going to go to the AV bundle, so the atrioventricular bundle, which is going to travel down the heart between your left and right ventricle. Then we have the bundle branches, so it's going to branch off a little bit to the bundle branches, and then it's going to reach what are called the Purkinje fibers, kind of look like a tree in the fall, or after the leaves have fallen off of it, and those fibers are going to turn around and travel back up. So just real quickly, if you're writing it all down here, because some of this will come up again, SA node to AV node, AV node to AV bundle, AV bundle to your bundle branches to your Purkinje fiber. So that is what's called the conducting system of your heart. All right, where is the SA node? The heart's pacemaker, I just mentioned that. It's in the back wall of your right atrium, and it sends a signal down your heart. That's why when they're doing an EKG, they're looking for signals from here down your heart. That's why when they use a defibrillator, they're sending a signal down your heart, the same kind of path that your heart would naturally use. So that's where it is, in the back wall of the right atrium. Next, where in the conducting system is there a delay in the electrical signal, and how long is the delay? So that's going to be at the AV node. So the SA node is going to depolarize both the atria. Think of like throwing a big rock in water and just see ripples go in every direction. So your two atria get depolarized, and now they're ready to contract. There's a delay right then. That's 100 milliseconds long, and it's at that AV node. Reason for that? The atria have to contract first. You don't want the ventricles to contract before the atria have done their job, because what's the job of the atria? To fill the ventricles. So the atria contract first, the lub, then there's a delay of 100 milliseconds. Then you have the dup. When the two ventricles contract, they're full so they can do their job better. So that's why there's a delay. So how long it is 100 milliseconds, and then a tenth of a second, and then where it is at the AV node. So you go SA node to AV node, a 100 millisecond delay, then you travel the rest of the conducting system pathway. All right, that answers both of those. On an EKG or ECG, what is the P wave, the QRS complex, and the T wave? So first of all, it is an ECG, electrocardiogram, but they call it an EKG because the guy that developed it, Eindhoven in Germany, that would have been a K. So electrocardiogram. So really it's kind of paying an homage to the developer of the technique. But an EKG is fine, but it technically would be, in the US anyways, would be an ECG, but both are perfectly fine. So the basics of an EKG, you'll see a P wave, a QRS complex, and a T wave. So the P wave is going to be when those two atria depolarize. So the little P wave will be your left and right atria depolarizing. The QRS complex is going to be when your ventricles depolarize prior to your two ventricles contracting. And the T wave is going to be when the ventricles repolarize. So hopefully you remember from A&P1 that depolarization is when a nerve fires, when a nerve is turning on whatever it's controlling. Repolarization is when the off switch is hit. So P wave, atrial depolarization prior to the two atria contracting, QRS complex, ventricular depolarization prior to the ventricles contracting, and the T wave is the repolarization of your ventricles. Which leads us to the obvious question then, why can't you see where the atria repolarize on an EKG? So an EKG is just measuring electrical activity. The reason you can't see this is the ventricles are depolarizing at the same time. So it's hidden. The repolarization of the atria is hidden inside that QRS complex, which is the ventricles depolarizing. It's just a more powerful signal. Not a big deal, but that's, if you're wondering, that's why it's missing. All right, if you see, a problem on an EKG, what is it called? So this would be an arrhythmia. I mentioned earlier that if you hear something wrong with the heart, it's a murmur. If you see something wrong on an EKG, it's usually an arrhythmia. All right, just a few more here. Define systole versus diastole. So hopefully you recognize these terms from blood pressure. Systolic over diastolic blood pressure. So systole means contraction, diastole relaxation. So the full cardiac cycle is going to be, you'll have atrial systole when the two atria contract, then atrial diastole when your two atria are relaxing, ventricle systole when your two ventricles are contracting, and then ventricular diastole when the two ventricles are relaxing. So that's systole versus diastole. So if your blood pressure is 120 over 80, that's your systolic over diastolic. What it's really saying is when your heart is contracting, the blood pressure is 120. When it's relaxing in diastole is when it's at 80. So systolic over diastolic. We'll talk about blood pressure when we get to the next section on blood vessels. All right, your normal heart sounds are labeled S1 through S4, so S1, S2, S3, S4. Which two are the most important? So there are four, but S1 and S2 are by far the most important. When you hear people talking about the heart, what you usually hear is lub-dup. Lub-dup. Some say lub-dub, but lub-dup is what you usually hear. So S1 would be the lub, and that's going to be when your two AV valves slam closed. The dup is the S2 heart sound you're going to hear. That's when your two semilunar valves are going to slam closed. So what you're really hearing with your two heart sounds, lub dup, is the valves slamming shut, like you're slamming a door. Okay. The other two heart sounds, S3 and S4, they're usually hard to hear in most people. Sometimes they're impossible to hear. Usually you got to have really good stethoscopes in a really quiet room, and be good at it to hear them. But they're just due to the flow of blood. So a lot of times you won't hear those, but they are considered normal. So if anyone ever talks about S3 or S4 heart sounds, we're not talking about it being a pathological condition. All right, define stroke volume and cardiac output. So these are very important. So your stroke volume is how much blood you move per beat. So stroke volume would be how many milliliters of blood can you move per contraction, right, per beat. Your cardiac output is your stroke volume times your heart rate. So that's going to be how many milliliters or probably how many liters of blood you're moving in a minute. So you take your stroke volume, which is how much blood moves per contraction, times your heart rate, which is how many times your heart contracts in a minute, and that's how you get your cardiac output. So stroke volume, how much blood moves per beat. Cardiac output, how much blood moves per minute. Stroke volume times your heart rate. Okay, then and this ties into the next point, last point, what is your cardiac reserve? Cardiac reserve is your resting output, how much your heart's working when you're resting, like me just sitting here, versus maximal output, doing interval training, the hardest thing you can do, sprinting upstairs, whatever. So how much more can your heart do than it normally does? So the best numbers here would be the average person has a resting cardiac output of about 5 liters per minute. Compare that to a well-trained athlete is able to move 30 or more liters per minute of blood. So 5 liters a minute is resting, but they can actually move 30 liters a minute of blood. So that's going to be their cardiac reserve. How much more can they do? If you're an untrained person for a short period of time, you probably can move about 20 liters of blood a minute, but obviously not for a very long time compared to a well-trained athlete. This is why athletes usually have really low heart rates and good blood pressure, because, especially the heart rate thing, because their heart at rest is like, man, this is a cakewalk. This person has me do hours of training a week where I have to work way harder than this. This is nothing, right? But if you have a desk job, you don't move a lot, this is about as hard as your heart has to work. So there's not going to be a huge reserve. So that's what your cardiac reserve is. All right. I truly hope this helps you guys. Have a wonderful day. Be blessed.